Thank you so much, Dr. Albert Chang, for inviting me to talk here. Let me see if this microphone works. Okay, yeah, great. I'll just grab this. So for today, I will be giving an overview of the research, but before I do so, I wanted to talk a little bit about my background, what is it like to practice medicine in the United States, and what it's like to be a psychiatrist. For this talk, my research is partially funded by the NIMH, the National Institute of Mental Health, and I have no conflicts of interest. So we'll talk about the career path, practicing in the US, and the research. I wanted to start with a map. I'm a big proponent of maps because they kind of detail where someone's from, and they also have quite a big relevance in the population I study. So I'll start with myself. My mother grew up in Taipei. My dad's from Guangzhou, but I was born and raised in New York City. I was particularly raised in this blue part. Let me see if I could, you see my mouse. Yeah, you see the mouse. So I was born in this this turquoise color called Queens. And Queens in the United States is probably one of the most diverse neighborhoods. A lot of different ethnicities, races, and there's a big, Chinese and Taiwanese community there. And that was where I'm from. And that's quite a big relevance because this is like the subway stop that I grew up taking. This is like how a typical my neighborhood looked like. I lived in a pretty disadvantaged place. These buildings are kind of called the projects, and there's a lot of immigrant, a lot of people don't speak English there. It was quite poor. I went to a school with 40 students per teacher. I actually did not do well in school before. I almost failed third grade. And my performance was very disappointing to my parents. And I want to show you this because there was this magic shop. Growing up, I really, really liked doing magic tricks. And it helped me this was like a community for me. I went there and I didn't feel different from other people. I could be a little bit different and that could be celebrated. It would be something good instead of, oh, you're being weird. This was a place for me to find community. And the reason why I bring this up is because a lot of my experiences growing up and how I've kind of attributed a lot of my successes to was because of my ability to form connections with people and have community, especially this magic shop. And that inspires me to ask a lot of the research questions about how environment plays such a vital role in mental health. This inspires, some of the research I've done. How does neighborhood poverty impact hippocampal volume, and how does social engagement mitigate and buffer some of these risks? These have potential for a lot of this finding. Has been disseminated to the public and has reached a lot of other physicians as well. So kind of back to where I grew up. So I grew up in Queens, and the places of the stars are where I've spent my time or an academic career. So as Dr. Chang kind of pointed out, I did my bachelor's degree at Columbia University. That was in New York, and then Hofstra was also in New York. It's kind of in the Long Island area. And then I did my MD there, and then after doing my MD, then I matched to Emory University for additional training in psychiatry residency, and then became an attending, and then I wanted to get more training in research, so I did a PhD in psychiatric epidemiology, and you can see that was in Europe. Maastricht University is in the Netherlands, and I can talk more about why I did my PhD there as well. So currently I'm in Atlanta, Georgia, which is down here. This is where I'm currently at and practicing as a psychiatrist, and that's also where I did my psychiatric training. The reason why I chose this training place is because when I was back in New York at Hofstra, one of the psychiatrists I was rotating with, we saw patients together and we did research together. His name was Michael Compton, and he was such a great psychiatrist. And I do a lot of research, but I'm a psychiatrist first and foremost, and I really appreciated the way that he took care of patients, and he did his training at Grady. There are a lot of different training sites in the United States, but there's not everywhere you get to see schizophrenia a lot. So in Atlanta, Georgia, you see a lot of cases of schizophrenia. And I practice at a public hospital, so there are a lot of different hospitals training, mainly 3 types in the US. We have private hospitals, where they take insurance. There's public hospitals, which is open to anyone, even without insurance. And then there's the VA, which are for military individuals. So I practice at this public hospital, safety net for anyone who comes in. And there's a lot of cases of newly diagnosed first episode psychosis. I'm part of the associate director of the first episode psychosis clinic here at this hospital, where when individuals aged 20s and the early 20s first have the onset of hearing voices where no one else is there, or seeing things that other people don't see, they come to our clinic, and then we provide really early intervention. And so this is downtown Atlanta. This is where I practice currently, and I also did my training here as well. So just a kind of a couple of facts about practicing in the U.S. As I mentioned before, I did my undergraduate. That's 4 years of undergraduate training, then 4 years of medical school, and then we do residency to 3 to 7 years. And then for some specialties, there's a fellowship for subspecialties. So it's a long time of training if you're going to do practice. If you want to do your education in medicine in the U.S. We also have a licensing system. It's called the USMLE. I think there's also a similar licensing system in Taiwan. The cost is very, very high. Sometimes the medical school often exceeds $200,000, and that's on the low end of medical debt, leading to a lot of debt. And I'm still paying off some of my debt. These are things that are important to know. For licensing and regulation, each state has its own medical board. So I'm medically licensed to practice in Georgia, for example. But if I want to practice in other states, I would have to get my licensing there, a different license. And then physicians must maintain continuing education credits. So for the work environment, the average attending physician work week, it's about 50 to 60 hours, and it really varies by specialty. Appointments, we would like appointments to be 30 minutes, but sometimes they last 15 to 20 because there's a lot of different patients and there's a high need. Fortunately, I work in a very specialized clinic, so I actually spend up to an hour with each patient and family as it can be very complicated. And sometimes when patients are really, really sick, this is a little unusual for my practice, but we would travel to their homes instead of relying on them to make the appointments. Sometimes they're so sick. I had this patient with catatonia who was stuck, and it was difficult for them to come into the clinic, so I would travel and meet them at their home to assess them. This is a very not so typical, but in the U.S., the state has set aside 10% of their funds for these first episode psychosis clinics, and that is because of the research finding that early intervention is helpful to delay decline later on. So, there's a lot of room where research actually affects the way that our healthcare system funds certain programs. But other than that, there's a lot of administrative burden that can sometimes deter people from practicing with insurance. So many times we see psychiatrists in the U.S., especially a lot of my colleagues, they take cash only because they don't want to deal with the insurance paperwork. And the EHR means the electronic health record requirements. The compensation, the salary vary pretty widely. For primary care, it's an average $200,000 to $250,000 a year, and specialists make even more, especially in surgical fields. So the income is generally pretty high compared to others. Like I said, for the healthcare system, there's a mixed public and private system. There's no universal coverage. It would be really nice to have universal coverage, but we unfortunately do not have that in the U.S. The patient's costs to see doctors are very, very high, very administratively complicated. The U.S. actually ranks very low on our overall health system performance compared to other high-income nations. So some of the challenges, like I said, are the administrative burden. There's malpractice risk. There's a lot of they carry liability and face potential lawsuits. Healthcare system can be very complicated, navigating insurance, billing, patient access issues. But some of the rewards is that it's pretty high job satisfaction from helping patients. There's a lot of different opportunities for research, teaching, and leadership roles, especially if you're in the academic sphere of practicing medicine. And there's a really strong demand. There's not enough physicians, so there's job security in terms of that. Life practicing as a psychiatrist, if you can practice in different kinds of settings. You can do a private practice, which a lot of my colleagues actually go into. It offers a lot of autonomy. You can do what you want. It's flexible, but you're the one also managing the business aspects of running a practice. Some people are hospitalists, so they work inpatient for the patients who stay in the hospital for severe mental illnesses, and you often collaborate with the medical team, surgical team, and taking care of patients with comorbid conditions. You can also practice outpatient clinic, which is what I mainly do. We have an outpatient clinic where patients generally are more stable, so then they come and you focus more on therapy and prevention. There's academic institutions, so you do teaching, you work with residents, medical students, you have clinical duties and research. And what's being increasingly very popular in our field is telepsychiatry. After COVID, and especially the post-pandemic, a lot of the visits are done virtually. And of course, even if, you're seeing patients virtually, our first visit or occasionally, routinely, they will have to come in to get blood draws or things like that. For the daily responsibility as a psychiatrist, we conduct psychiatric evaluations, we prescribe medications, and then sometimes also provide psychotherapy. There's documentation. We have to document in the electronic health record, and many times some physicians complain about a lot of time being spent doing this, but it's also really rewarding since you work with other healthcare providers like psychologists, social workers, primary care physicians. In my case, I work with a lot of peer supporters, and they help develop a lot of the rapport and to check in with the patients on a day-to-day basis. And continuing education, we have to maintain licensure and stay updated on the new treatments and effective strategies to engage with patients. And while work hours are typically 40 to 60 hours per week, for psychiatrists, compared to other specialties, we have more of like a good work-life balance, I would say. And we sometimes have on-call duties, so sometimes I will cover for the entire hospital. I will see all the patients on the weekend, and sometimes that occurs probably for me 3 to 4 times a year. So it's pretty flexible if you're in academia, private practice, telepsychiatry. Some settings over other offer more flexibility than others, but also depends on what your interest is in and what you enjoy for your practice. Outside of work, I like to play piano. I play the drums as well. I still do some magic, not as much as before, and I like good food, which is one of the reasons why I've been enjoying Taiwan a lot. And and I feel like practicing as a psychiatrist offers a pretty good work-life balance. So before I move on to the research area, I want to check and see if anyone has any questions for the first section about just in general practicing psychiatrists. Anything before I move on.
Yeah, any questions? Anyone want to practice psychiatry in the future? Please.
Hello. As far as I know, having a therapist is far more common in the U.S. than in Taiwan. And I just wonder how the therapist and psychiatrist interact, or do they interact at all? That's my question. Thank you.
That's a great question. I've worked a lot with psychologists, and I think it differs depending on different fields. Psychologists, usually we would recommend a certain type of therapy. So for example, a very basic one is cognitive behavioral therapy, which has been really evidence-based treatment for many disorders, including anxiety and depression. So many times we will make a referral for them to see a psychologist, or sometimes when we're not sure about the diagnosis of a patient, it can be kind of difficult. We often want a second opinion, and we often do it for diagnostic clarity or for other modalities of specialized therapy treatment. And in those times, it's really helpful for them to work with a psychologist. I think it's easier in an academic institution where you know your colleagues and oh, this psychologist does this type of therapy well, or that therapy. And especially for some of my patients with OCD, the exposure therapy has been really, really helpful. Sometimes we do the therapy as well, but many times we collaborate a lot with a psychologist, and whatever they write in the records and the notes has been tremendously helpful for us. When we look at their notes, where we often sometimes talk with them about like how the treatment is going and how the direction is, and we kind of work together to kind of figure out the best way moving forward. I think it's especially important for cases where patients they don't respond to treatment, like the medicine as well, and so we have to think about, or they have a lot of side effects, to kind of figure out what are the best routes to kind of help them. But in general, I think we work pretty hand in hand.
Any other questions?
Great.
Yep.
All right, so I'll move on to the next portion. So I want to start with a map again, because this time the map means something different. This is a map of Chicago. So it's one of the cities in New York, in the United States. And what I'm showing here is that these researchers, Ferris and Dunham, back in 1939, they found that there are higher schizophrenia rates, as denoted in the darker colors, in the inner city parts of Chicago. So you can kind of see the inner cities are here, and there are a lot of cases of schizophrenia that they found back then. And they realized that cases of schizophrenia, incidents as we call it, which are new cases, they tend to aggregate in certain places. So there's this relationship between place and mental illness, specifically schizophrenia. They were one of the first researchers to find this connection between where people lived and mental illness. And they thought that this was because, these places tend to be more disorganized, people don't really follow the same rules. There's a lot of, disorganization in these areas, and that may lead to schizophrenia. But with these kinds of cross-sectional studies at one time point, they've been criticized because we don't know if people who have schizophrenia go to these places, or these places then lead to schizophrenia. Since then, a lot of the research on looking at neighborhoods and schizophrenia, which are smaller areas, have been done mostly in Western Europe. And since then, we find that looking at all the different research, that this relationship between city living and psychotic disorders, including schizophrenia, we find that is true in a lot of different countries, not just in the U.S. And there seems to be a dose-response relationship where the more urban the area, and if the person grew up there, they will later on develop psychotic disorders. And this is very specific to non-affective psychotic disorders. It does not apply to depression or anxiety. So there's something very specific about this environmental factor. And the timing is important too, where growing up in urban areas, not currently living in urban areas, is a risk factor for developing non-affective psychotic disorders. just a kind of a framework of how we think about place and health. We kind of, this kind of field of study is called the social determinants of mental health. How many people in here have heard of the social determinants of health? Can you raise your hands? Has anyone heard of this? Oh, you've heard it. Okay, cool. One person. Okay. Well, the social determinants, just to kind of give a broad overview, where we work, play, live, these things, matter a lot in terms of our health. So we can kind of see, if you go from bottom to up, we see that policies, social norms in our culture, they lead to kind of the different distribution of opportunity. Some people, who live in areas where there's a lot of, there's not enough access to treatment, or there's not enough food, that can impact greatly their health. And so when a patient's walking into our door, we often don't think about the upstream factor that led them to the condition they have. So for example, if someone walks in your door and they have something like high blood pressure or diabetes, that is oftentimes, there's a reason for that. Well, if you ask why, well, because they haven't been taking their blood pressure medication. Well, why is that? Well, maybe it's because it's hard for them to access the medication. Well, why is that? Well, because they live in an area where they don't have access. And if you keep on asking the why, you get to other systemic factors that lead patients to have certain bad outcomes. So those are, that's kind of how we conceptualize where someone lives and kind of their outcomes. So we have these unfair opportunity, and that leads to all these different boxes, like, food insecurity, poor access to healthcare, low education, unemployment, poverty. And this is especially important in the United States context because opportunities are distributed very unequally in the U.S. Now, they happen everywhere, but it's especially prominent in the United States. And you see a lot of people, like I showed you some of the pictures, there are people living on the streets, there are people who are very isolated, and a lot of those things then leads to reduced options, poor choices, behavior risk factors, stress, and then that also then leads to mental health, like adverse outcomes. So when we're conceptualizing neighborhoods and how living in certain places will lead to even things like schizophrenia, keeping in mind, this framework in which we think about, all the different things that leads a person to developing these symptoms. In terms of neighborhood factors that are implicating schizophrenia and other psychotic disorders, back in 1939 with Ferris and Dunham, they have already identified 3 really important neighborhood factors that predict the onset of psychosis, and they're living in poverty, living in places of social fragmentation, and places of low ethnic density. So I'll go through probably just the first 2 because of time, but if I have more time, I can talk about ethnic density as well. So for studying the onset and the development of schizophrenia, we look upstream at youth who are at clinical high risk. So what does that mean? So there are some children, adolescents, or young adults who come into our clinic and they don't have full-on schizophrenia. They don't have psychotic symptoms. And what I mean by psychotic symptoms is like people who hear voices when no one's around, or they think that someone's trying to poison them when no one's trying to poison them. And those are pretty serious onsets of those disorders. But even before then, we can detect kind of what's called prodromal, or symptoms that we call CHR, or clinical high risk. So they're at high risk of developing them. They kind of have a little bit of those symptoms, but not yet full-blown. And we try to study, in the children and adolescents who are at high risk, and then try to track them to kind of see, well, who then develops schizophrenia or who doesn't develop. So a lot of the research that we conduct is kind of following these individuals and then trying to see, are there brain differences, are there genetic marker differences, and I particularly was interested in what neighborhood differences do they come from. So this is part of the data that I'm using is part of, it's called the North American Prodrome Longitudinal Study. It's in North America. It's about these prodromal individuals, and we do a longitudinal study. We follow them for at least 2 years. We just finished a 10-year follow-up study, actually, with them. And you can see Emory, where I'm from, we were part of recruiting participants for this. So this is like the stage of psychosis I kind of talked about. We start seeing symptoms arise, the age of late adolescence, and then we can see this symptom kind of go up, and it waxes and wanes. And this is the first episode time when they get when the symptoms become more severe. And then you can kind of see that as the symptoms become more severe, their behavior adaptation, their functioning starts lowering. And this is the usual age of psychotic symptoms in their 20s. For males, it's usually in the 20s. For females, it's a little later. And you can kind of see that this is sort of the trajectory of people experiencing psychosis. And we're trying to study on the period in the psychosis risk to see what is going on in their biologically. So these are the different sites across the U.S., and here's Emory again. We're one of the 8 sites, and this really requires a consortium of different sites to get enough power to study these individuals. So back to the study that I was talking about, where we looked at individuals' neighborhoods and how poor the neighborhoods are, and how the relationship between that and a specific area in the brain called the hippocampus among individuals at clinical high risk. The reason why we study the hippocampus and look at this brain region specifically is because this area of the brain is very sensitive to stress. It is full of what's called glucocorticoid receptors. So if you remember the HPA axis, glucocorticoids, they form in response to stress, and the more stressful the conditions, it kind of feeds back onto the hippocampus, and it is very sensitive to these hormones, like glucocorticoids. It's an area of the brain that's particularly rich in this area and very sensitive to environmental stressors. This area of the brain is also highly implicated in schizophrenia. We see people with schizophrenia and healthy controls, and those with schizophrenia tend to have a smaller hippocampal volume. In order for us to assess if they're at high risk, clinical high risk or not, we ask them about different positive psychotic symptoms, like do you have unusual thought content or suspiciousness, grandiose ideas, do you perceive things abnormally, or disorganized communication. This battery of tests takes a long time. It's like 3 to 4. I've done some of these, and they take because you can't directly ask, you have to kind of assess them through a clinical interview. There's also other shorter versions we've adapted since then, but in general, if they meet 3 to 5, then they are at high risk. If they're at 6, they get excluded because they have psychosis, and if they're 1 to 2, they're questionably present. We put them at more of the clinical healthy comparisons category. So they have to meet 3 to 5 to be included as the clinical high-risk group. So how do we assess for exposures? So participants were given their addresses at baselines as a way to contact them. And initially, that was all that information was ever used. I contacted the 8 sites to link their addresses at baseline to publicly available census data. And in their neighborhoods, we can look at what is the percentage of individuals who are living in a census tract whose income is in the prior year was below the poverty level. And a census tract is defined, we use that as a proxy for measuring a neighborhood. It's about 4,000 people who live in a census tract. It's smaller than what's called a zip code or postal code, and it's quite homogeneous in terms of neighborhood characteristics. So with publicly available data, knowing where they're living, we linked that information to their addresses. And we used the survey at that year in which information was collected to match their exposures. And neighborhood poverty is just one of them. We can link air pollutants, social factors, so on and so forth. we define social engagement as kind of adding up different activities that they have endorsed, such as being greater involvement in church, synagogue, neighborhood, and other organization, took a vacation, took a new hobby, sport, craft, acquired a pet, and made new friends. And this is on the right showing the distribution of the social engagement total score. Now, this is less than perfect, ideal way of measuring this, but this was kind of what I could gather as a way to look at ways that individuals have engaged socially. For hippocampal volume, we used different scanners, and we also corrected for the scanners using Combat, and we used FreeSurfer to parcelate the different regions of the brain. We adjusted for study site, the different MRI manufacturer, and their overall intracranial volume. For the analysis, we included a lot of potential confounders. So these are things that could explain the relationship between neighborhoods and hippocampal volume. So those included things like their age, their sex, their race, ethnicity, their family history of mental illness, their own personal household income, their parental education, and their self-reported life event stress. And then we looked at the moderator being social engagement as an interaction term, and we corrected for what's called multiple comparisons. We included 174 participants, and these are their demographic characteristics, mostly white, non-Hispanic participants. And when we looked at the relationship between the level of neighborhood poverty and hippocampal volume, we see that there's this inverse relationship. Here's shown a scatter plot of this relationship, but we generally see an inverse relationship, such that the greater the poverty in the neighborhood, the smaller the hippocampal volume, even after adjusting for all those potential confounders. However, when we looked at the interaction with social engagement, we see that those with greater engagement with their community, making new friends, that's shown in a dotted line. So we see that the relationship between poverty and hippocampal volume is no longer significant among those groups, but it's only really significant among those with lower social engagement. So is it really, what is really impacting hippocampal volume here? Is it really the level of economic poverty, or is there something social going on in their neighborhoods? And I think that, for poverty, it may be a proxy for what may really be driving the smaller hippocampal volume, which is kind of their social environment may be particularly important if we're finding that there's this moderation effect. So, when we're looking at data like this, that was just cross-sectional. It was a small sample. Doing good science is always trying to replicate your work and trying to find different data sets to replicate and looking at this in different ways. So one of my colleagues, Deanna Barch, and her students also found that there's a relationship between neighborhood poverty, cognitive function, and prefrontal hippocampal volumes in children. This is using what's called the adolescent brain cognitive development data set that looked at over 11,000 children, ages 9 and 10. And they also found that greater levels of poverty was associated with reductions in right hippocampal volume. But in their measurement of poverty, they use an index called the Area Deprivation Index, and it's like a mix of a lot of different factors. And what I noticed was that there were two factors that particularly measure the social environment, namely this percentage of single-parent households and percentage of homeowners. And I'll go into what I mean by that in a bit, but I wanted to kind of tease out which of these factors are mostly driving hippocampal volume. Is it really the social environment or more economic? So I delved deeper into this data set to look at aspects of this deprivation index and what's driving hippocampal volume. And these are the different sites in a different data set. It's called the ABCD data set. We used a stepwise backwards elimination and adjusted for a lot of the similar covariates. And what we found was that there's generally the greater the single parent, so the single parent households was the only neighborhood factor that was driving, out of all the other neighborhood factors, was driving reduction in hippocampal volume. But what was really interesting was that positive school environment, they reported being in a better school environment, including better interaction with peers and teachers. That seemed to also buffer the effects of neighborhood single-parent household on right hippocampal volume. And interestingly, the positive family environment, although it is important, did not seem to interact with neighborhood single-parent household. So is it something about social environment with peers that may be important, or people outside the community? That's something that we're further investigating. So, hopefully by kind of showing, what I've shown so far, the notion is that not all stress has the same impact. So when we say that this is a bad environment or a bad neighborhood, there may be distinct aspects about the neighborhood or the environment that can impact neurobiologically what's going on. And this is a kind of a model that someone has kind of created, basically that places, if you're very lonely and you don't have a lot of connection, those effects are very different than someone exposed to very threatening situations, even though they may both confer risk for mental illness or other adverse outcomes later on. So the way we conceptualize different exposures is that perhaps single parents or homeowners, they're part of the category of social fragmentation, which is distinct from the socioeconomic status. Are there unique mediators or similar pathways, and how do they then confer risk for similar outcomes? So I mentioned social fragment a couple of times. What is social fragmentation, and how do we operationalize or define it? So this is a area level factor, so also a neighborhood level factor, and it's composed of four to five different area level factors, and empirically measures the disruption of social ties and relationships among residents and families and communities. And you could kind of, the distinction of places that are very fragmented versus those that are not is quite apparent, especially when, I was just in, coming here or going to a very rural area, or being in a place like Atlanta where there's a lot of disorganization. It's something that it's noticeable when you are transitioning or going to a different neighborhood with different levels of fragmentation. This is based on the social disorganization theory, which posits that things like social norms, social cohesion, collective efficacy, these are very essential factors that contribute to a child's development and their mental health and how they conceptualize the world. Our review found that places that have high fragmentation, there was a 4 to 12-fold increase in the prevalence of and hospitalizations related to schizophrenia. So it's measured by these factors. So percentage of people who moved, also known as residential instability, percentage of renters or homeowner occupied housing being reversed. So how stable a community is, the percentage of single person households for adult exposure or single parent households for childhood exposure, and percentage of unmarried people. And what we're finding is that exposure to places like this that have high fragmentation, particularly during childhood, has adverse effects, and I'll show you the different evidence for that. So, going back to the Naples data set, we found that living in places with high instability was associated with earlier age onset of psychosis. We also found that and that was a data set in using patients from our clinic in Atlanta. And then using the Naples data set, we showed that exposure to residential instability during childhood was associated with greater odds of conversion to psychosis among youth at clinical high risk, and even among those who never moved themselves. If they live in a place where there's a lot of movement, that also predicted greater odds of conversion. Neighborhood fragmentation was also associated with greater distressing psychotic-like experiences, and especially among those with fewer close friends. And these relationships persisted even after adjusting for known risk factors like cannabis use, neighborhood poverty, household income, race, ethnicity, and general life event stress. And so what we're seeing is that the childhood exposure is particularly important. So this is a study we did looking at social functioning, on how a person functions, not just their symptoms, as this is one of our a really important outcome, how well they are to adapt to their society and live a meaningful life. And we see that during their childhood, when we asked them where they lived for the longest time during childhood, if that place was very fragmented, when we looked at their fragmentation during childhood, it was not related. But the functioning was more related when we follow them, and in young adulthood, we looked at their functioning and there's decline. We see that there's a strong relationship of this phenotype and the environmental exposure. So when we look at environment and health, sometimes we have to consider lagged effects. Sometimes, there may be exposures occurring at one time point, but the effects you may not see it long after. And we see that this could potentially be mediated. Well, we did see that there was partially mediated by maladaptation to school, kind of similar, very consistent what we found with the moderation of the school environment. And we found that this relationship between fragmentation and functioning was particularly prominent among those with clinical high risk. So you see on the right, on the left side, we see those at clinical high risk being in the dotted line, and we see that this relationship of fragmentation and functioning was particularly prominent. But for those who are healthy comparisons, we do see a slight, a relationship, but it's not as prominent. And this is another group. This was a study on the right done in Spain, not my research group, but they found that neighborhood social vulnerability was related to greater disability, and particularly with patients with first episode. But this relationship was not really prominent among healthy comparisons. So these findings kind of indicate that maybe those with high risk, maybe there's something that they're particularly sensitive about their neighborhood environment. Not everyone who lives in a particularly fragmented area may be affected, but maybe there are certain people, maybe there's prodromal symptoms or maybe genetic vulnerability, maybe at higher risk. That was in Naples phase 2, what we found I just showed, and we replicated those findings in the phase 3 of the Naples when these are completely different subjects, and we try to tease apart neighborhood social fragmentation and just general socioeconomic deprivation, like poverty, low education. And when we put this in a structural equation modeling, with these proposed mediators and functioning, what we found was that social fragmentation had a unique direction to peer rejection, and that was in turn related to lower functioning, but socioeconomic deprivation did not go through peer rejection, but instead through community disorganization, which was shared with social fragmentation. This is kind of consistent with the notion that there may be similar and different pathways of different types of environmental factors leading to the outcome. So what are potential neurobiological mechanisms? So we looked at one of the important factors in terms of functional connectivity. And this is just, we took MRI scans of these patients at clinical high risk. This is part of Naples. And they're just resting. And we looked at their BOLT signal, which is the blood flow to certain parts of the brain. And we looked at how connected the relationship of each brain regions to another. And because of our findings of the hippocampus, we set that as the seed, and we looked at the relationship of the hippocampal area to other parts of the brain. And when we looked at all the connections, that was our outcome of interest. And we looked at the neighborhood social fragmentation as the exposure. And what we found was that the greater the fragmentation that they currently lived in, that was associated with higher hyperconnectivity of normally connected parts of the hippocampus to what's called the TPJ, the temporal parietal connectivity. And this is an area that is particularly important important in facial recognition and social interactions, has been found in many, many other studies. So it's interesting that this objective exposure is also related to abnormalities of this brain region, the social brain region. And this was particularly prominent among those with lower social engagement, but the relationship was not there if they had higher engagement with their community. Another thing that we found was EEG. So we also put EEG headsets. I wish I showed a picture of it for these patients at clinical high risk and also healthy controls. And it just measures the brain activity when they're being kind of exposed to auditory oddball tasks. So if there's like a pattern of sounds that they're hearing, you suddenly change the sound pattern, we will see how their brain responds to that. So usually people respond to that, and you see a change in their brain waves. But for those that with schizophrenia or those at clinical high risk, you see that there's an impaired mismatch deviation, and this mismatch of deviation. It could be sounds, it could be visual stimuli. We look at if we change the frequency of the sounds or if we change the duration of the sounds, how much impairment is there? And this is a particularly important biomarker that is very specifically linked to schizophrenia, not linked to other mental illnesses, and is also specifically linked to their impaired functioning. So I thought, is this also impaired in people who are living in these fragmented areas? And we can see that those living in higher fragmentation, there's more impairment of this mismatch negativity impairment, and this is particularly important relationship among the people who are at clinical high risk, but not really for those at healthy comparisons. But this is also very small sample, but we need to replicate this in a larger study. But this is kind of giving some clues as to what are some of the neurobiological mechanisms that may be at play here that leads a person who are living in these fragmented areas to develop psychosis. And the reason that this is really important in our conceptualization of what's happening, because if we're thinking that if someone is growing up in a place where things are changing or very disorganized, they're going to be developing a conceptualization of the world that they cannot rely on new information. And what we think is going on is that if a place is changing around so much, they're going to be relying more on what's prior information and having trouble updating their beliefs. And if they have issues with updating their beliefs, that can kind of tip someone, in terms of the aberrant salience model, to be more liable to hearing voices that are not there or experiencing abnormalities. So this is kind of our conceptual model of how being in a disruptive social environment and maybe to psychosis, and a lot of studies using animal models where they will isolate mice and rats, they've also shown that these animals have impaired mismatch negativity, and they've also looked at other environmental stressors like threats or putting them in threatening situations, which did not impair their mismatch negativity, showing that, implying that there may be some specificity to different types of environmental exposures leading to psychosis or psychosis-like behaviors in other animals. So this is kind of, when we reading different literature in different fields, it's interesting that perhaps, the fields can have some alignment in terms of what we think may be going on. So what we think could be going on is, after disruptive social environment, we may first start seeing fMRI changes or mismatch negativity, but then later on in time, we may start to see more structural changes, and then the development of more phenotype later on. That's our working hypothesis, by the way. So, in kind of summary, the social fragmentation, as opposed to more general socioeconomic status, is related to psychosis outcome, and the impact of exposure on outcomes may depend on timing. We see that childhood exposure to fragmentation associated with future impairments of functioning, for example, and then we see neurobiological changes may occur at different times, but perhaps we can use them to capture changes before they develop develop changes in phenotype later on. So what are some of the potential interactions with genetics? I looked at the social environment by looking at neighborhood factors, but there are other ways to capture the social environment, and it's important to use different methods to kind of show similar findings. We looked into the ABCD data set, and our outcome of interest here were psychotic-like experiences that are persistent and distressing. So we know psychotic-like experiences are even before these prodromal symptoms. They were assessed in children, and actually they're quite common. 60% of kids experience some of these psychotic-like experiences. They may be like, oh, someone's in the closet, the boogeyman or something like that, and it's usually not that distressing, and it usually is transient, it goes away. But if these symptoms, these experiences are really distressing for a child and they persist on, then they are more likely to predict later on psychopathology, including schizophrenia, but not only schizophrenia. They could also develop depression or anxiety. So we investigated in this particular study how genetics interacted with the social environment as operationalized by involvement in team sports and predicting these persistent distressing PLEs. So this is using the ABCD data set. We looked at these psychotic-like experiences using 21 questions, and we looked at this across 4 years. So if they have 2 or more of the years that meets a distressing level, then they're categorized as either having persistent distressing or not. So we assessed these psychotic experiences among 9 and 10-year-olds. So we showed them these distressing pictures, and they would rate how distressing they would feel for each of the 21 items. We first looked at the polygenic risk score for schizophrenia by looking at all the common SNPs that are associated with schizophrenia, and we find that there is a significant difference between those with no PLEs versus those with persistent PLEs. But we don't really see a difference between them with no PLEs and transient PLEs in terms of the level of their genetic liability for schizophrenia. And for looking at team sports, so we looked at there's like this questionnaire and even objective way of categorizing their level of physical activity by looking at their Fitbit activity, by asking them how much they're involved with sports, by even their caregiver report. So we use all 3 to measure their physical activity. And there's some literature about how physical activity may be a protective factor for psychosis. It's a much stronger literature for depression, actually. Psychosis is a little more mixed. But I thought that among those, the physical activities, if they are more involved with team sports that encourages more social interactions, that I think that could be also explained, according to my theory with social environment, I think that could explain a lot of the protective effects of psychosis. So TS on top just means team sports, IS means individual sports. So I took all the physical activities and I parsed them into these 2 categories. And what we're seeing is that those with distressing PLEs, they tend to have less involvement in team sports, but not individual sports. So some people may ask, well, maybe their genetic liability may be affecting them doing sports or not, or team sports or not. But interestingly, in this particular data set, we did not find association between their polygenic risk score for schizophrenia and physical activity or team sports. But we did find that there was an interaction. So here on the x-axis, we see the level of genetic liability for schizophrenia, and the y-axis is their likelihood of having this distressing psychotic-like experience. And we see that this relationship was particularly prominent among those with lower levels of team-based sports, in this really light blue. But in those who have a lot of more involvement in team-based sports, we see this relationship not be significant, suggesting there may be some protective effect of team-based sports against the genetic liability for developing psychotic-like experience. But of course, this is just tracking across the first 4 years, and we did not account for changes in team-based sports or physical activities. how do neighborhood factors then interact with genetics? Some of the research that I've shown you so far, we looked at particular neighborhood factors in isolation. We looked at poverty, social fragmentation, but we're forgetting a lot of other neighborhood factors, and these neighborhood factors may be highly correlated. So, in our field, we're looking more at the totality of a lot of different exposures altogether and trying to account for the other exposures to tease out what may be driving the effects. So we constructed the exposome in two different ways. First, by clustering neighborhoods into distinct profiles, and the other way is to create a total, neighborhood exposome score. And then we want to look at the association between exposome and PLEs, and also figure out if physical activity could be related to both the neighborhood and to our outcome of interest because of our previous findings on physical activities. So we went back to the ABCD data set. We looked at 29 different neighborhood factors, including the deprivation index, childhood opportunity index, crime, lead risk, air pollutants and noise, racial and non-English speaker composition. We created something called the SOM, which is a machine learning approach to cluster observations of similar exposure profiles. And then we also adjusted for potential covariates, including age, race, ethnicity, parental educations, as well as site and family groups as random effects. So this is how a SOM plot looks like. So you can see that for this particular data set, we had 5 different profiles of environmental exposures. These are all geocoded at the neighborhood level. And we see that all the different colors represent a different neighborhood factor. And they're all coded or reverse coded such that the longer the bars are, the worse the outcome is. So you can kind of really tease out the different types of neighborhoods. There could be neighborhoods high crime, low poverty, high crime, high poverty. So you can kind of see and disentangle the highly correlated factors. You can see how many percentage of participants each participant gets assigned to each profile. And you can kind of see the distribution here. I will focus particularly on 3 and 4 since they were the only ones associated with psychosis. 3 is categorized by these rural areas that have low walkability and high ozone. And 4 are more urban areas that have really high crime, high pollutants, and high socioeconomic deprivation. And we use another method, the weighted quantile sum, which is combining everything together. And we want to see, if the overall exposure was associated with psychosis and what neighborhood factors in this overall exposome was driving it. And again, we see walkability or lack of walkability as one of the driving factors. When we looked at the interaction of this neighborhood exposome altogether with polygenic risk score for schizophrenia, we see that there is a significant interaction, but it's the opposite of what we expected, such that neighborhood seems to matter more for predicting psychosis among those with lower genetic risk, and the other way around. The genetic risk predicted psychosis, but just among those with people being exposed to less neighborhood adverse effects. So, in conclusion, I wanted to share that, there's several lines of evidence pointing towards the importance of social environment, measured both at the individual and neighborhood levels. And the impact on neurobiology, psychosis may depend on timing. The interactions are really important to, I think, investigate together for more personalized and ways of conceptualizing how they may both contribute to psychosis. And there are many other, factors and other ways of looking at this that I didn't really get into, but this is sort of the main points of my talk. So I'll just open it up for questions again, and I'll stop here.
Okay, so I think there are lots of information. So any question to Dr. Koo?
Thank you, Dr. Koo. I'm currently a sophomore in medical school, and I was thinking that could the amount of time people spend on social media or on internet also be a social determinant of developing some psychotic-like symptoms? Yes, that's all for my questions.
Yeah, no, that's very true. I think there's a lot of emerging evidence on, a lot of people, and the majority of the literature looks at screen time, how much time you spend using social media, and its relationship to psychosis, and even using things like ChatGPT or other AI chatbots have been associated with psychosis, psychotic-like experiences, and even suicide. I mean, that's been a very big thing in the news. The question, though, is like, what are the different aspects? How do we tease out what types of, is it about just scrolling? Is it engagement? Is it different types of platforms? I think more research is really needed to kind of investigate this a little deeper in terms of what aspects of social media. But I definitely think that there are other aspects that may contribute or may coincide with psychosis. Well, we also have to tease out, like, if someone's developing psychosis already, are they using social media differently as opposed to social media platforms causing the development? So I think longitudinal and really carefully looking at this longitudinally, I think, will be really important. But there's already emerging evidence for a lot of these things, but we still don't exactly know the mechanisms.
Any other questions? Maybe following on that, so I'm just wondering that suppose you find some social determinants of the psychosis, is that possible that we can use the digital tools like maybe social media platforms, so that's one way, but there's digital tools like cell phone apps that can, reduce the risk or even reverse the trend?
Yeah, I think there's potential for it to be helpful in some ways. If they're, I've shown that, social engagement, making friends, and these kinds of things are quite important. But I also think that I think the biggest thing is being part of a community where, you can go to your neighbor's house, or a child can just go over to their neighbors and play there without fearing that, there's a stranger danger, or having shared values. And I think these things that are very, very important that we don't see a lot in the U.S. But the aspect of community and being part of something and feeling like you belong is I think that's the key thing. If social media can tap into that, I think that could maybe buffer some of it, but I think the real thing is that sense of community.